It's a pleasure to be with you. The title of this talk is Improving Adult Vaccination Rates. Much of the material for this talk is adapted from the National Foundation of Infectious Diseases webinar, Strategies to Increase Adult Vaccination Rates from February 6, 2019, provided by Dr. Robert Hopkins, Chair of the National Vaccine Advisory Committee and Professor of Internal Medicine and Pediatrics and Director of the Division of General Internal Medicine at the University of Arkansas Medical Sciences College of Medicine. There are no disclosures for this presentation. Objectives include review the importance of immunizations in controlling infectious diseases, review 4 keys to developing a successful adult immunization program, discuss 5 tips for developing an immunization quality improvement program, review CDC immunization standards, review common adult barriers to immunizations and suggested solutions, discuss approaches to address hesitant, questioning, or fearful patients, and review the importance of patient and provider recall systems and standing orders. The CDC demonstrated that the lifespan of Americans increased by approximately 30 years from 1900 to 1999. 25 of those years were due to public health interventions. 5 years could be attributed to healthcare advances, including medications like antibiotics, surgical technology, or life support. The 10 health achievements that significantly impacted lifespan in the 20th century included vaccinations, the most effective public health tool in history, motor vehicle safety, safer workplaces, control of infectious diseases, including water protection, sanitation, etc., declines in cardiovascular heart disease and stroke deaths, safer and healthier foods, healthier mothers and babies, family planning, fluoridation of water, and recognizing tobacco as a health hazard. Many of these achievements were accomplished through public health professionals working in collaboration with other stakeholders, including healthcare colleagues. These public health interventions that worked so well in the 20th century are still important in the 21st century, including vaccinations and how to effectively improve vaccination rates in adults, the focus of this talk. This table vividly demonstrates the impact of vaccinations over the past 120 years. Notice the marked annual percent decreases in all of the diseases listed, ranging from 91% for pertussis to 100% for smallpox, diphtheria, and paralytic polio. This emphasizes that vaccinations are historically the most effective public health tools to reduce morbidity and death worldwide. This slide lists some key disease targets that could be significantly impacted by better vaccination strategies. Influenza annually is the cause of 140,000 to 710,000 hospitalizations in the United States and results in an annual U.S. influenza-related death rate of 12,000 to 18,000. This was estimated from the 2017-18 influenza season. Pneumococcus annually causes 900,000 cases of pneumonia, resulting in 400,000 hospitalizations. It's estimated that between 700,000 to 1.4 million people in the United States have chronic hepatitis B that places them at increased risk for liver cancer. Human papillomavirus, HPV, is the annual cause of 27,000 cancers in both men and women in the U.S., with 4,000 women dying each year from HPV-associated cervical cancers. This is the 2019 CDC recommended adult immunization schedule by age group. Like the immunization schedule for children, the adult schedule is complex. Many adults are often not aware of their current immunization status. Therefore, recording the administration of all adult immunizations in healthcare system electronic health records and the state's immunization information system, IIS, is critical. Not only is recording each adult immunization in these systems important, but also reviewing the patient's immunization status in those databases with each healthcare encounter. It's critical to inform their care and provide them with accurate immunization information and vaccinations. Age-related immunization recommendations are demonstrated in this table. There are additional vaccination recommendations based on underlying medical conditions and other indications like pregnancy, immunocompromising conditions, chronic diseases, etc. Clinicians and their staff members charged with immunizing children and adults need to be well versed and familiar with current immunization recommendations. The CDC's Advisory Committee on Immunization Practices, ACIP, is constantly evaluating data and making appropriate changes to the U.S. immunization schedules. The ACIP is CDC's Advisory Committee on Immunization Practices and sets United States policy for immunizations. There are 15 voting members, 36 non-voting liaison members representing key professional and academic organizations, and 8 ex officio federal members. The ACIP meets 3 times per year. Media are often present at these meetings, and every meeting provides time for public comments. Meeting transcripts and slides are available after each meeting at www.cdc.gov/vaccines/ACIP. After each ACIP meeting, the National Foundation of Infectious Diseases, along with organizations like the North Dakota Public Health Training Network, provide reviews of the ACIP meeting's deliberations and recommendations, along with pertinent background information. This slide summarizes key concepts for a successful adult immunization program. 1. Build an immunization team. This applies to both inpatient and outpatient venues and includes develop and utilize an immunization quality improvement process, QI. Assure that vaccine providers and staff understand vaccine science and recommendations. This often requires regular education on immunizations, current recommendations, and schedules. These providers and staff members not only need to know the science, but be committed to the importance of immunizations and the primary prevention concepts of personal and community immunity. Healthcare providers and staff are often the final line of defense for patients with concerns and objections to immunization. 2. Use tools to maximize vaccinations, including reminder recall tools, electronic health records, EHR chart advisories, standing orders, and state immunization information systems, IIS. 3. Strategically target interventions to those you have a chance to help. 4. Develop and use effective communications, tools, and messages. This slide lists some practical tips on developing an immunization quality improvement program. Number 1, assemble a team representing all constituencies in the immunization process. This would likely include clerical and managerial staff members and clinicians, including nurses, physician's assistants, nurse practitioners, physicians, pharmacists, etc. This slide lists common immunization team members for inpatient and outpatient vaccination programs, including a chief vaccination officer, the vaccination expert, who provides technical vaccination information and informs and influences program vision, case managers, who develop pre-visit vaccination plans. This includes identifying gaps in vaccination coverage by reviewing patient vaccination records via traditional and electronic systems, including state immunization information systems, IIS. Case managers use this information to develop vaccination plans based on appropriate schedules. They also often are responsible for sending out reminder recalls via various venues, including phone contacts, texts, or emails, traditional mail, etc. The intake clerk primarily implements and assures an efficient and welcoming registration process, including the completion of preclinical information sheets, insurance information, etc. Clinical providers, including physicians, nurses, nurse practitioners, physician assistants, etc., complete the clinical visit and provide other clinical and vaccination support services. This commonly includes implementing protocols and vaccinating patients. These protocols often include direct clinician orders and standing orders, etc. Clinicians are critical providers of vaccination information in one-on-one clinical settings, but also in public venues. In the clinical setting, vaccine information sheets are extremely helpful to disseminate important vaccine information. Clinicians often have opportunities to interact with and answer questions for vaccine-hesitant patients and families. They may collaboratively interact with other vaccination stakeholders, like pharmacies, school student health services, state and local public health, other healthcare institutions, etc. Clinicians are often tapped to educate office staff on vaccine-related issues. Clinicians are also tasked with maintaining up-to-date patient vaccination records, most commonly contained in electronic health records, EHRs, and state immunization information registries, IIS. These real-time records are essential sources of information for the office manager to maintain the clinic's vaccine inventory. State and local public health will also monitor available vaccine data to maintain state and local public health vaccine inventories. Checkout personnel are commonly assigned to assure a pleasant and supportive checkout experience, including the scheduling of follow-up visits based on EHR and IIS data in line with ACIP schedules for age and risk factors. In many clinics, checkout and intake personnel are the same individuals. The office manager essentially makes the whole clinic run smoothly. Their tasks commonly include the monitoring and control of inventory, oversight of billing and collection processes, assess and provide cost analysis information, etc. This may include determining if it's more cost-effective to vaccinate in the clinic or network and refer to other venues like pharmacies, etc. Office managers develop vaccine clinic strategies. For example, walk-in clinics for vaccine only have been shown to increase adult vaccination rates. The main point is that a vaccination team, if organized and run well, will increase adult as well as other target groups' vaccination status. Number 2, assign a Chief Vaccination Officer, CVO. The CVO is critical to the success of an immunization program. This person would be the immunization expert that oversees the whole immunization program. 3, set SMART goals. Objectives or goals should be SMART. SMART is an acronym where the S stands for specific. The goal needs to be clearly stated and should answer questions like who, where, what, and why. The M stands for measurable. What parameter will be used to determine if you have reached the objective or goal? This parameter will obviously inform the evaluation process. The A stands for achievable. Does this goal seem reasonable within available and accessible internal and external resources? The R stands for relevant. Will this objective or goal help accomplish the mission of the group and organization? The T stands for time-bound. When will this objective or goal be accomplished, providing a realistic target and element of accountability? In addition to goals being SMART, an accountable individual also needs to be assigned to coordinate and assure the goal is achieved. Without that assignment, nothing happens. Number 4, develop an evaluation system. There are 3 main categories of tools for evaluating population-based programs like immunizations: formative, process, and outcome evaluations. Formative evaluation provides information that helps plan or initiate a program. Process evaluation commonly assesses participation in activities that are assumed to result in a desired outcome. Outcome evaluation measures are the actual desired end product. Formative evaluation would primarily relate to the planning function of management. Process and outcome evaluations would be part of the controlling or adjustment function of a program. Therefore, process evaluations are often used as early measures or surrogates for final outcomes. An example of process evaluation for immunization programs would be measuring the percent of a target population receiving influenza vaccinations during a fall influenza immunization program. Getting influenza vaccinations is presumed to impact the number of individuals infected, severity of illness, clinic visits, hospitalizations, and deaths due to influenza in the target population, which are the true desired outcomes. Both process and outcome evaluations are important to determine immunization program efficacy. As previously mentioned, process is generally an early evaluation tool and outcome a later measure. Number 5, utilize the performance or quality improvement QI cycle. Program effectiveness is the ability to set the right goals and consistently achieve them. That usually is accomplished through a common cyclical performance or quality improvement process of 4 stages. 1, formulate a plan based on formative evaluation data and analysis. This is the grand entrance to the cycle. 2, implement the plan. A good enough plan, not a perfect plan, is what is needed. 3, review the plan. This is essentially via process and outcome evaluation data and analysis. 4, readjust the plan based on results of the evaluation. Research has shown that high-performance groups were brutally honest with the evaluation data and utilized that data to make key adjustments to their plan. The cycle continues since planning is not meant to be static but dynamic. Programs must flex and adjust to be effective. It's important to utilize 4 key adult immunization standards that inform immunization clinic operations and policies, including 1. Assess immunization status of all patients at every encounter. This implies that clinic personnel are aware of the latest CDC vaccine recommendations for adults. This also includes ensuring that at each encounter, the patient's vaccine needs are reviewed and that those needs are entered into a viable reminder recall system. 2. Strongly recommend vaccines that patients need. Share reasons why the recommended vaccines are important. Highlight positive personal experiences with vaccinations. Address patient questions and concerns. Explain the potential costs of vaccine-preventable diseases, including quality of life and economic costs to the individual and family. Remind patients that vaccines protect them and their loved ones against many common and serious infectious diseases. 3. Administer needed vaccines and/or refer patients to another vaccine provider. Offer the vaccines your clinic stocks and refer patients to providers in the area that offer vaccines you don't stock. Public health immunization clinics are often referred patients from providers that have limited stocks of vaccines or for economic reasons have decided not to provide immunizations. Integration and networking of public health with other providers is essential. 4. Document vaccines received by patients in patient records, electronic health systems, and the state's IIS, Immunization Information System. Participate in your state's vaccine immunization registry system. This not only helps inform your clinic and staff about the vaccine needs of your patients, but also provides other providers who serve your patients information they need to assure that appropriate vaccines are offered at every encounter, both in your clinic and in other providers' offices. 5. Follow-up. Confirm patients have received recommended vaccines from providers you referred them to. This table lists some common patient barriers along with suggested solutions. Fear and misconceptions can be addressed by using appropriate vaccine educational materials like vaccine information statements and proactively discussing vaccine safety, the real dangers of vaccine-preventable illnesses, and concerns about adverse vaccine effects like pain at the vaccination site, etc. Vaccine history needs to be reviewed at each patient encounter in both the inpatient and outpatient setting, and needed vaccines recommended. Lack of access can be addressed in several creative ways, including holding express vaccination-only clinics, offering extended clinic hours for vaccinations, providing vaccinations in non-traditional settings like workplaces, shopping malls, grocery stores, etc. Lack of awareness can be addressed through use of reminder recall procedures and venues, including telephone calls, postcards, email and text alerts, etc. For patients who have an inability to pay due to a lack of insurance or high copays, etc., clinic administrative financial counseling should be available during vaccination clinics to explore all options in a creative way to find financial solutions. Clinics should plan for and use translators and appropriate translated materials to address language barriers. This slide lists some of the barriers for adults receiving pneumococcal vaccines, but likely applies to other vaccines as well. The top barrier was feeling that the individual was healthy and didn't need pneumococcal vaccine. The second most common barrier was that their clinician or doctor didn't tell them they needed the vaccine. This underlines the importance of clinicians reviewing vaccine history and strongly and effectively recommending vaccines at every clinic encounter. Providers who consistently recommend vaccines have significantly higher patient immunization rates and has been shown to help reduce racial and ethnic disparities in vaccine coverage. It's important for the clinic to make vaccine recommendations a part of every routine patient encounter, along with the taking of vital signs and the reviewing of health histories. The Chief Vaccine Officer, CVO, along with other clinical leaders, must assure the engagement of all staff members in the vaccine effort and assure there is a consistent message from those team members, including the case manager, intake and checkout personnel, clinicians, and administrators. This slide demonstrates the importance of provider recommendations on adult vaccination rates for influenza and pneumococcal vaccines. Without a recommendation, the rates ranged from 15.8 to 27%. With a recommendation, those rates jumped to 82 to 85.1%. The way we communicate a recommendation to patients is important. There are essentially two major ways to make vaccine recommendations: participatory or presumptive recommendations. An example of a participatory recommendation is listed here. Would you like an influenza vaccine today? This implies that you can either get it or not, and leaves the patient with the impression of uncertainty. A presumptive recommendation would be the following: I strongly recommend we give you the influenza vaccine today to prevent the flu. Do you have any questions about that? This statement implies that the vaccine is essential for health and wellness, like diuretics for heart failure or antibiotics for an infection. Presumptive recommendations are much more effective than participatory ones for increasing immunization rates. This slide summarizes individuals who influence adults to get immunized. Notice that the personal clinician is the greatest influencer, particularly in individuals who are 65 years old and older. Once again, supporting the importance of strong recommendations from clinicians. Family members are important influencers, particularly for those in the 18 to 26-year-old category. Notice also that celebrities are not high on the list. Celebrities are often tapped for public service announcements, assuming that they will have significant impact on decisions. That is not the case. Yet having said that, it is important to seek creative ways to encourage messages from all those that influence the decisions of patients, including clinicians, family members, and celebrities. Focusing on only one silo of messaging will not be as effective. To explain why celebrities have limited influence, let's briefly discuss horizontal and vertical communications systems, an important concept in engaging communities on various issues, including immunizations. These concepts are covered in more detail in other sessions of the North Dakota Public Health Training Network. Every community has respected individuals, generally informal leaders or horizontal communicators. These are the go-to people of the community who have exceptional skills to influence community members. These individuals are called by a variety of names in the literature, including horizontal communicators, influential individuals in class, opinion leaders, peer communicators, and champions. A major strategy of community engagement is to identify and adequately engage the horizontal communication system of a target community. A horizontal communicator may be recognized as the go-to person in one area of interest, like health, yet may not be a recognized authority in other areas like faith-based, economic, political areas, etc. The horizontal communicator for health issues may be a health professional, like a nurse, physician, nurse practitioner, chiropractor, etc. For spiritual issues, it may be a tribal medicine man or woman or elder in a church. For political issues, it may be a community activist. It is important to identify the appropriate horizontal communicators for specific areas of messaging in community engagement. All societies have elements of class and status. Class is defined as a continuum between open and closed. Open societies allow relative ease of communicating and moving between classes versus closed societies. The United States and England would be considered open societies, where India and Spain are more closed. Generally, there are three social classes in each community: upper, middle, and lower. Class is associated with certain behavioral expectations and is fairly well defined. For example, a person living in a certain part of town may be associated with a certain social class. Certain jobs may be associated with class. For example, a physician or lawyer may be considered upper class in some communities, where other jobs may be associated with the middle or lower social classes. Superimposed on the class system is a status system and roles. Status is the social position assigned or achieved by an individual. Role is the acting out of one's status. Every member of a society or community has his or her statuses and roles. A man may have the status of son to his mother, physician to his patients, and elder in the church. In each of these statuses, a person is expected to fulfill certain roles or behaviors. Generally, people want to interact with people of equal or higher status and seek to move up in status with every opportunity. With that last statement in mind, a person can generally only significantly impact those of equal or lower status. Influential individuals are located at the upper end of each class in a community. These individuals are those informal leaders, the horizontal communicators, peer communicators, opinion leaders, influential individuals in class, and champions. These individuals have exceptional ability to change the beliefs, values, and resultant behaviors of those in their class, but equal to or below them in status. These last few slides point out a complexity of community engagement. Appropriately engaging horizontal communicators in each class and who are identified as community opinion leaders in specific areas like politics, health issues, spiritual matters, etc., that were previously discussed. Failure to appropriately engage the right messengers may result in program failure. This is an important slide demonstrating horizontal and vertical communication between classes. Both horizontal and vertical communication is important for successful community engagement in changing risky behaviors. Communication from a higher class to lower class, vertical communication, generally results in high prestige, medium message volume or capacity, and low to medium persuasion potential. This would be like utilizing a movie or music celebrity or professional athlete as a messenger. Public information officers often seek out these types of individuals since they have broad name recognition, yet realize that these celebrities will only have marginal persuasion potential. They often suffer from silver spoon syndrome. Comments often heard include, They don't understand the reality of life in my situation. It's nice that they care, and I respect them for that, but they don't totally identify with my needs. Low to higher class communication we'll call reverse vertical communication is generally poor, associated with low prestige, message volume, and persuasion. Horizontal communication is generally associated with moderate prestige but high message volume and persuasion. The utilization of horizontal communicators is a major tenet of true community engagement. Finding well-respected individuals of high status within their class who can effectively communicate horizontally within their class. Horizontal communicators are often informal, not formal leaders, and include family members, peers, respected individuals of high status within each class. These horizontal communicators have incredible potential to influence community and individual behaviors. A main point is that horizontal communicator messages within each class of a target community is generally the most effective communication method to change behaviors, including improving adult immunization rates. Using this SHARE acronym helps structure vaccine messages to cover key topics to improve vaccine coverage. The S stands for sharing reasons why the recommended vaccines are right for the patient's given age, health status, lifestyle, job, other risk factors, etc. The H stands for highlighting your own experiences with vaccinations to reinforce benefits and strengthen confidence. The A stands for addressing patient questions and concerns about vaccines, including side effects, safety, and vaccine efficacy, using plain and understandable language. The R stands for reminding patients that many vaccine-preventable diseases are still common in the United States and can be serious. The E stands for explaining the potential costs of getting infected with a vaccine-preventable disease. This would include the serious health impacts, time lost for work or family interactions, financial costs, etc. There are many vaccine-hesitant individuals. These next few slides provide some valuable suggestions for planning for and managing those patients. The clinic vaccination team needs to utilize strong and specific consistent messages and recommendations from every team member, including administrators, clerks, case managers, and clinicians. Strong, specific, and consistent messages include those in verbal and written venues. Written messages and recommendations include vaccine prescriptions, posters, and vaccine information sheets. Making a diagnosis is important. Is the patient saying no or I'm not sure? Are they hesitant, questioning, or fearful, falling into the I'm not sure category, or are they an anti-vaccine zealot that state an unequivocal no? Refer hesitant, questioning, or fearful patients to a closer, which could include a physician, nurse, pharmacist, or other vaccine champions, etc. Many experts suggest investing clinic time and resources on the hesitant, questioning, and fearful versus the immovable zealots. Document your diagnosis in the medical record. This slide lists some suggestions for a closer's approach to patients who are hesitant, questioning, or fearful. Address the specific concerns of hesitant, questioning, and fearful patients. Make presumptive vaccine recommendations as previously discussed. Document a vaccination plan in the medical record along with the reasons for vaccine concerns, the diagnosis. Ideally, the closer will convince the patient to receive their vaccination during the clinic visit. For those who are still undecided, the closer should encourage a specific time to revisit and address outstanding concerns. It is critical to develop a follow-up plan for these patients and utilize reminder recall systems. People have different learning and decision-making styles. While you may not achieve your goal in one visit, good provider-patient relationships will go a long way in helping you reach your goal. Reminder systems are commonly used in two ways to improve vaccination rates. Reminder recall systems for patients and reminder systems for providers. Patient reminder recall systems have been shown to increase vaccine coverage by 12 to 20%. These systems can use various message venues, including telephone, letters, email, text, secure messages via electronic health records, etc. Clinics often use multiple venues to help ensure patient contact. These reminder recall systems may also be used to provide other educational materials based on patient risk factors like asthma, smoking, diabetes, etc. Provider reminders have been shown to increase vaccination rates by 12 to 16% overall and up to 50% for influenza and pneumococcal vaccines in some studies. Provider reminders are commonly used for pre-visit planning by a case manager. They are also commonly used as electronic health record EHR alerts that capture the attention of clinicians entering a patient's record. Standing orders are a key strategy to increase adult immunizations. Standing orders help avoid missed vaccination opportunities by allowing non-prescribing clinicians, members of team-based care systems, to administer vaccines without prior direct prescribing clinician orders for an individual patient. Standing orders save primary care provider time, empowers staff, helps meet quality metrics, and can be used in inpatient and outpatient settings. Standing orders are recommended by the CDC Advisory Committee on Immunization Practices, ACIP, and the U.S. Preventive Services Task Force, USPSTF. Standing orders are also endorsed by the Centers for Medicaid and Medicare Services, CMS, to increase vaccination rates. This slide lists 5 key standing order components. 1. Specific vaccine or vaccines are listed and strongly recommended. A common statement used by the vaccinator may be, your primary care provider strongly recommends this vaccine, for example, influenza vaccine, and wants you to have it today. May I give it to you now? Number 2, the patient is appropriately screened for precautions and contraindications and appropriately addressed by the protocol. Number 3, the patient is provided with appropriate vaccine information statements, VIS. Number 4, the vaccine is appropriately administered per standing order protocol. Number 5, the vaccination is documented as specified in the standing order. This may include entry in an electronic health record and/or state immunization registry, etc. State immunization information systems, IIS, have been very useful and are commonly used for documenting childhood immunizations in the United States. They unfortunately are not as commonly used to document adult immunizations, but should be. This slide lists the results of various efficacy studies of standing orders. Overall, standing orders increased vaccination rates in adults by 28%. For influenza, the increase ranged from 25 to 37%. For pneumococcal vaccine, the increase was 21%. This slide lists some helpful tools, sample protocols, best practices, and other useful resources for standing orders. In summary, provider presumptive recommendations are critical. Develop a vaccination team. Utilize reminder recall systems for patients and providers, standing orders, and immunization information systems to facilitate adult immunization program efficacy. Establish protocols to deal with hesitant, questioning, and fearful patients.
Take your public health practice skills to the next level. Our specialized certificate courses give you an opportunity to work systematically through a public health topic and demonstrate your understanding of that material in a capstone project. Learn more and sign up at ndphtn.com/certificates.